Welcome everyone to our first internal medicine review series. Our first session of our first series is rheumatology. And I'd like to introduce Dr. Kothari, who is the chair of the Department of Medicine and chief academic officer at St. Peter's University Hospital. He also serves as the program director for the St. Peter's Internal Medicine Residency Program. Dr. Kothari has no financial or non-financial conflicts of interest related to this activity. And this program is being accredited with Category 1 credits for CME. There's a total of 6 credits that you'll be able to claim at the end of the series. You'll also be able to claim MOC points. And to claim credit, go to acp.org, Internal Medicine Review Rheumatology Series, log in, complete the post-test for each module, and at the end of the series, you will be able to log into the course and complete your evaluation and claim your credit. And with that, I turn it over to Dr. Kothari.
Thank you, Teresa. Good evening, everyone. Welcome to the ACP New Jersey Review in Internal Medicine. I'm Dr. Kothari. On behalf of my fellow governor, Dr. John Samaz, and Governor-elect Dr. Sapru, Dr. Teresa Barrett, and Cindy Martin, I want to welcome you on behalf of the ACP. This is our first module. We hope to do modules in every discipline over the next 6 to 7 months. This will be for 2 hours, and I'm going to do the rheumatology. The first thing I want to do is to look at the American Board of Internal Medicine Foundation Choosing Wisely campaign. As you probably know, American Board of Internal Medicine has a foundation. They came up with a Choosing Wisely campaign. It is worth downloading in your phone. It's free. Since it is an ABIM campaign, I would expect that a lot of questions in the board would be originating from there. So I'm just going to go over some of the rheumatological questions. Number 1, do not do imaging for low back pain within the first 6 months unless red flags are present. And we will discuss going forward what are the red flags. Do not test for ANA subserologies such as double-stranded DNA, Smith, RNP, SSA, SSB, SCL70 without a positive ANA. If ANA is negative, all those tests would be negative anyway. So there is no point in ordering what is commonly known as a panel. You also need clinical suspicion to order those tests. Next slide, please. Next slide. Do not test for Lyme disease as a cause of musculoskeletal symptom unless there is a clear-cut history of exposure and appropriate exam findings. Because lots of times Lyme test is ordered on a false premise and then a lot of unnecessary workup evolves. Don't perform an MRI of the peripheral joints, such as small joints of the hand, to routinely monitor inflammation in the joints. Do not prescribe biologics for rheumatoid arthritis without giving methotrexate first. Next slide, please. Don't routinely repeat DEXA scan more than once every 2 years. And of course, you all know this, avoid NSAIDs in a patient with hypertension, heart failure, any chronic kidney disease, and all causes with including diabetes, all causes of chronic kidney disease with diabetes. Next slide, please. So we are going to jump in vasculitis. It's an inflammation of the blood vessel that may cause stenosis or obstruction, ischemia or aneurysm or hemorrhage. So if you know those 4 things, you should be able to tell signs and symptoms of any form of vasculitis. Next slide, please. One of the many ways to determine vasculitis, to classify vasculitis, is by the size of the vessels. You can do a pathological classification. There are some clinical classifications, but I like this the most. And depends upon the size of the vessel. So big vessel, large vessel, aorta and its branches will be Takayasu and GCA, giant cell arteritis. Medium vessel is classic is polyarteritis nodosa, Church-Strauss syndrome, Cogan syndrome, a very favorite question in the boards, Kawasaki disease, and Burgers disease, thromboangiitis obliterans. Small vessel would be cryoglobulinemia, Henoch-Schindler purpura, and Wagner's granulomatosis. And on the venous side, the classic is Behçet's disease. Please note that there is a significant amount of overlap in this classification. So for example, one can have a giant cell vasculitis, but they may also have at the same time small vessel vasculitis. Next slide, please. We are now going to discuss different types of vasculitis. And number one, which is clinically very important, is polymyalgia rheumatica. It has never been reported below the age of 50. So that itself should rule out the diagnosis. It is a systemic disorder which may give you fever, fatigue, weight loss, and the key is diffuse pain and stiffness of the girdles, shoulder girdle and the pelvic girdle. When you ask patient, do you have pain? They will say, no, doctor, I don't have pain. I'm stiff. And that is a distinguishing point. And it has a dramatic response to low dose prednisone, like 10 milligrams of prednisone, what we call the hug and the kiss response. If a patient is so miserable with polymyalgia rheumatica, they cannot get out of bed, they cannot dress themselves, their spouse have to help them to do things. And when you give them 15 milligrams of prednisone or 10, they completely unfreeze, and next day they will come and hug you and kiss you on both cheeks. That is your diagnostic test. If you don't get a hug and kiss response, it is not polymyalgia rheumatica, it's something else. Next slide, please. GCA is a part of the spectrum. It has systemic features such as fever, anemia, anorexia, malaise, weight loss, abnormal enzymes, ALT, AST, etc. And it has a local features, headaches, visual symptoms, blindness, scalp necrosis, very rare, and jaw and tongue claudication. It depends upon which vessel is involved. If the artery to the masseter is involved, you will have a jaw claudication. And if you have a lingual artery involved, you may have a tongue claudication. And one of the consequences of GCA is aortic arch syndrome. You develop aortic aneurysm and dissection. The classic patient will be a patient who is 75 years old, typically a woman, comes with headaches, and probably will say, I have a TMJ syndrome. The TMJ syndrome is not temporomandibular joint, it is claudication of the jaw. And many times this patient ends up in a dentist office and they get all kinds of bridges and equipment in the mouth, and it turns out to be a giant cell arteritis. They also have a flu-like illness, which is a generalized body pain. The key is this flu-like syndrome goes on for a month, and you all know that the flu doesn't last for a month. Next slide, please. Important rules of GCA: never delay treatment. The rule is, if you think about GCA today, you should have given steroids yesterday. Biopsy may be delayed up to 20 weeks. Many times this happens. Well, I have a patient with GCA, but I can't get a biopsy, temporal artery biopsy for 2 weeks. Don't worry about it. Treat the patient. Biopsy will not change for 2 weeks. Long-term complication of GCA is aortic aneurysm and dissection. So the learning point here is that once you discharge a patient with GCA after 4 to 6 months of steroid therapy, you should call the patient back every year for a chest X-ray to make sure that the aorta is not dilating. There is some evidence that giving a low-dose aspirin, like 81 milligrams of aspirin, may prevent aortic dilatation and aortic aneurysm. That is not confirmed yet. Also, please remember that 1/3 of patients may have a normal SED rate. So do not ever discard the diagnosis of GCA or polymyalgia because the SED rate is normal. Next slide, please. The Takayasu arteritis is a counterpart of GCA, but in younger people. It's a granulomatous inflammation of the aorta and its main branches. It typically affects young women of Asian descent, though Caucasian women, African American women are not immune. The symptoms are, you can imagine, because it causes blockage of the subclavian and major vessels in the arms, it can have cool limbs, can cause headaches, and arm claudication. So how do you diagnose arm claudication? Patients have to use their arms. So activities like hanging curtains, painting walls, they may precipitate these symptoms. And when you examine this patient, they have unequal pulses, unequal blood pressure on both sides. And the diagnosis by an angiogram, you have to do an aortography. So the classic patient is a 40-year-old woman complains of pain in both arms on hanging curtains. Note that the age group is different. Age group is totally different. This is young people, middle age, 40, and the GCA is about 50, but mostly 70s and 80s. Next slide, please. This is an angiogram of the aorta and its main vessels, and you can see the beaded appearance of the main arteries, and that is diagnosis because you really cannot biopsy this tissue. Next slide, please. So talking about aortitis, we already discussed the GCA and Takayasu can cause aortitis. But there are other two which you should remember. One is spondyloarthropathies. We will discuss this probably today. And also syphilis. If we were in 1940s, and if somebody said, what is the cause of aortitis? You would answer syphilis. We still see syphilis and we still see aortitis. So always keep syphilis in mind. Next slide, please. We have a question, and I think you are supposed to answer this, and then we will see how many of you answer. I will read the question. An 80-year-old is seen in for physical examination required to join a hockey team. He was diagnosed with Kawasaki disease at the age of 5 years. No other records are available. Physical examination, including vital signs, are normal. Which of the following disease complications is most likely, most important in determining the nature of his sports evaluation and prognosis? Bundle branch block, coronary artery aneurysm, myocarditis, pericarditis, or hypertension? Please answer. 70% answered it, a correct answer for coronary artery aneurysm. I think a few of you answered bundle branch block and myocarditis. Remember that Kawasaki disease, otherwise known as, please go to the next slide. And you can close the poll. Kawasaki disease is I'm not sure whether I can close it from here. Oh yeah, I can. Kawasaki disease, the original description by Kawasaki, he called it acute infantile febrile mucocutaneous lymph node syndrome. The name is very important because if you know the name, you will know all the manifestations of Kawasaki. It's acute, it's infantile, typically 4 or 5 years of age, fever, and it causes mucocutaneous lesions as well as enlarged lymph nodes. Fever, rash, conjunctivitis, red lips, strawberry tongue, and cervical lymphadenopathy. The hallmark of this disease and the biggest scare is that it causes coronary vasculitis, which may result into aneurysm and stenosis at a later date. So the child is 5 years old, gets Kawasaki, gets treated. At the age of 16 or 17, he gets a myocardial infarction because of coronary aneurysms, coronary stenosis. The treatment for Kawasaki is intravenous immunoglobulins and aspirin. Note that corticosteroids are not effective. We will come back to this point a little later, but please remember the treatment is not steroids. This is one of the very few rheumatic diseases, inflammatory diseases, where cortisone does not work. Next slide, please. Another case. A 67-year-old man has a 3-month history of painful paresthesia on the dorsum of the right foot. Do not mistake right and left. Keep right and left together. He now stumbles back. He is unable to fully raise his right foot, again right. And he has developed paresthesias and weakness in his left hand. So he has a right foot motor and sensory problem and a left foot paresthesia and weakness, both sensory and motor. He has had fever and night sweats accompanied by arthralgias and myalgias. And he has lost 18 pounds as is systemic constitutional. He does not have joint swelling or morning stiffness. His temperature is elevated, blood pressure is elevated. He has evidence of livido reticularis. Livido reticularis implies small vessel obstruction, very tiny capillaries obstruction of the lower limbs. On musculoskeletal exam, he is unable to dorsiflex his right foot. So he has a weakness of the right foot dorsiflexor, and left hand is weak. And there is no signs of synovitis. Next slide, please. Hemoglobin is 10.5, ESR is high, creatinine is up. So now he has a not only neuromuscular disease, he also has renal disease. ANA is negative, ANCA is negative. He has an elevation of AST and ALT, so that means probably liver involvement. And then he has a hepatitis B surface antigen positive. Antibody is negative, so he's not immune, and core negative, B E antigen negative, hepatitis C negative, cryo negative, and urine analysis normal. So he does not have kidney involvement as such, like glomerulonephritis, but his creatinine is 2.1. Next slide, please. Which of the following is the most likely diagnosis? A. Polyarteritis nodosa. B. Acute hepatitis B infection. C. Scleroderma. D. Wagner. E. Cryoglobinemic vasculitis. Please answer. Okay. I think most of you got it. It is polyarteritis nodosa. Acute hepatitis B infection would not explain creatinine and other things. Wagner's, we'll talk about Wagner's. Cryoglobinemic vasculitis would not do this, particularly when hepatitis C is negative. Cryoglobinemic vasculitis is associated with hepatitis C. So let me walk you through the next slide. The polyarteritis nodosa is a necrotizing. Remember, the GCA was a granulomatous inflammation. This is necrotizing inflammation of the medium-sized vessel. So the first question is, what is a medium-sized vessel? It is some of the sub-branches of the subclavian system. It could be coronary vessel, like in Kawasaki. It could be mesenteric vessel. It could be renal vessel. And there are other medium-sized vessels I'll come to. It has constitutional symptoms, weight loss, fever, etc. And it causes mononeuritis multiplex and peripheral neuropathy. So what is mononeuritis multiplex? Mononeuritis means inflammation of one nerve. Multiplex means many places. So for example, in this patient, he had a left hand neuropathy and had a right foot neuropathy. Anatomically not connected. So what is the common link? Why does mononeuritis multiplex occur? It occurs because there is an involvement of the vasa nervorum. The vessel which supplies the nerve is a medium-sized vessel because it has a lot of muscle in it, muscularis, so it is a medium-sized vessel. If it affects the mesenteric artery, it would cause GI ischemia, gangrene, and death. It may affect the renal arteries. Mind you, it does not affect the glomeruli. It affects the renal artery. It can affect the skin, and until recently, 20 years ago, maybe 25 years ago, before the hepatitis B vaccine, 50% of patients with polyarteritis nodosa had hepatitis B infection. Next slide, please. The diagnosis is biopsy of the medium vessel. So how do you get a medium vessel? Testicular artery is a medium vessel. Now it sounds terrible to do a testicular biopsy, but the yield is very high. So one of the questions comes up, how do you get a tissue in polyarteritis nodosa? You can do a testicular biopsy, particularly if they have testicular pain. Or you can do an angiogram. The angiogram which is shown here is a mesenteric angiogram, and if you look at the vessels, they're beaded. That means there's obstruction, segmental obstruction, and that's your diagnosis. You can also do a blind nerve and muscle biopsy of the gastrocnemius. Because if you do a blind biopsy of the gastrocnemius, you might see a medium vessel and you may see inflammation. Please note that kidney biopsy is not the answer. because kidney biopsy will not yield a medium-sized vessel. It will only give you glomeruli, and the glomeruli are not affected in this condition. Next slide, please. Question again. A 35-year-old woman has had several episodes of paroxysmal vertigo over the past 4 months. The vertigo has been associated with intermittent hearing loss. So we have an 8th nerve problem. First right, then left. Mind that there are 2 of them. She was given amoxicillin for otitis media. Recently, she received meclizine without any benefit. She now presents with her eyes are red and very sensitive to light. So we have a ear problem and we have an eye problem. Which of the following is the most likely diagnosis? Meniere's disease, viral conjunctivitis, acoustic neuroma, Cogan syndrome, GCA. Please answer. Okay, I think most of you got the correct answer. It's a Cogan syndrome, which is a rare but interesting phenomena. I think some of you said Meniere's syndrome. I don't know why you would say that in a 35-year-old person. Why would Meniere's syndrome cause eye problem? Viral conjunctivitis would be very unusual, lasting for 4 months. Acoustic neuroma should not give you eye problem. We just discussed maybe 3 minutes ago that giant cell arteritis has never been reported below the age of 50. This woman is 35, so that itself should rule out GCA. The correct answer is Cogan syndrome. So if you would move to the next slide. Just go forward, please. One more slide. Okay, this is Cogan syndrome, a very favorite exam question. It's a form of a medium vessel vasculitis, and it causes interstitial keratitis. That is the picture on your left and middle. Scleritis and episcleritis. So you have a painful red eye with visual symptoms. And it also affects the vestibular and auditory abnormalities. So you may have a deafness and vertigo. And that is limited form of polyarteritis nodosa, and that is Cogan syndrome. In polyarteritis nodosa, the entire vasculature may be affected. In Cogan syndrome, it limits to only eyes and ears. Next slide, please. Church-Strauss vasculitis. The chief complaint of Church-Strauss vasculitis is asthma or rhinitis. The clue is eosinophilia, but as you know, many patients with asthma have eosinophilia, but they have additional features such as peripheral neuropathy, even mononeuritis, and they may have a GI involvement with the mesenteric arteries. There is some evidence, though not clear, that leukotriene inhibitors may be implicated in the causation of Church-Strauss syndrome. I don't think it has been proven. Next slide, please. This is the treatment of all vasculitis is the same. I will come to at the last slide to remind you. This is a patient who has purpura. If you feel the purpura, it will be raised. So when you have a raised palpable purpura, it only means one thing, and that is small vessel vasculitis. And the slide on the next photograph, no, please go back. Next photograph is a serum which has been kept in a fridge overnight. So is cryoglobulins. Years ago, when we did not have fancy tests, we used to, as residents, we used to spin the blood and put this tube in the fridge along with sandwiches, and next morning we came and saw cryoglobulin. This is a cryoglobulinemia. Next slide, please. And the only one, the type 1, is with the macroglobulins like Waldenstrom. We don't need to discuss that here, but type 2 cryoglobulinemia has more than one class of immunoglobulin. It is not monoclonal, and it is classically associated with hepatitis C. It's a small vessel vasculitis with palpable purpura. In other words, if you feel your hand over the legs, you will feel that the purpura is palpable. They can get neuropathies and synovitis. Next slide, please. And the treatment is that of hepatitis B. There are atheroembolism, cholesterol embolism, or pseudovasculitis. They're all same. The common belief is that you have to do something to the vessel. You have to put a catheter and probe it, but it can occur spontaneously. It may follow an endovascular procedure such as cardiac catheterization, or it can follow after a TPA or even heparin. The emboli travel all over the body and they can cause skin lesions. The classic skin lesion is livedo reticularis, or they can get blue toe syndrome. I will show you some pictures. It can go to the renal vasculature and can cause atrophy, not infarction, atrophy, and can cause a steady rise in creatinine, or it can go to the GI system and cause ischemia. Note that if you have emboli from atrial fibrillation to the kidney, you get a kidney infarct. But if you have atheroembolism to the kidney, you get atrophy. Atrophy is a time-consuming process, so it takes several days. So typical patient will have a cardiac cath on Monday, but the next Friday will have a rise in creatinine because it takes time. If a person has a clot from the atrial fibrillation, same day the creatinine will rise because there is an infarction. The clues are eosinophilia, eosinophils in the urine, and lowered complement. Why complement lowering occurs, we don't know. And diagnosis is by skin biopsy. If you have a skin lesion, you will see cholesterol atheroembolism. Next slide, please. Here are the 4 pictures. The picture on the upper left is livedo reticularis. Livedo reticularis is a network of capillaries where the blood flow is impeded. So you see a reticular network. It can occur in normal people when it's extreme cold, or it can occur with atheroembolism, or it can occur with small vessel vasculitis. Picture on the upper right is a blue toe syndrome, which is classic for atheroembolism. So if you have a patient who has undergone cardiac cath, and when you go at the bedside, remove the socks, remove the bed sheets, and look at the toes. And you'll be surprised how many times you will see the blue toe syndrome. Picture on the lower right is the fundi. These are the cholesterol embolization. That is diagnostic. You do not need to do any more tests. It's called Hellenhorst plaques. So you have to look into the fundi. Picture on the lower left is a postmortem specimen of the kidney and the aorta and a microscopic picture of the vessel. Look at the kidney, how small it is. It's a contracted kidney. Look at the aorta, it looks like a bark of a tree. So you can imagine a catheter going there and dislodging one of the plaques. And on the microscopic slide on the right, you see the cholesterol crystal stuck in a vessel. This is the entire picture of atheroembolism or cholesterol emboli. Next slide, please. An 80-year-old woman is evaluated for a rise in creatinine from 0.8 to 1.8. She has chronic rheumatoid arthritis for the past 15 years. She has chronic rheumatoid arthritis for the past 15 years and was treated with methotrexate, 15 milligrams every week, which is appropriate. She has difficulty to control hypertension and is on an atenolol, hydralazine, valsartan, and hydrochlorothiazide for control. So this is a refractory hypertension because she is on 4 drugs, one of which being a diuretic. In addition, she is on prednisone, methotrexate, and NSAID PRN. She should not be on NSAID when she has hypertension. Physical examination shows normal vital signs. Synovitis of the knees. Already people answered this. Okay. Okay, atenolols, NSAIDs. Okay, let me walk you through. The choices are atenolol, hydralazine, valsartan, and NSAIDs, and hydrochlorothiazide. NSAIDs and hydrochlorothiazide should not do this. The choice is, the correct answer is hydralazine. Please move to the next slide. This is not something which was known 5 years ago. Hydralazine, I think we all learned in medical school that hydralazine causes drug-induced lupus, but hydralazine also causes a vasculitis, which is totally separate from lupus. And then in retrospect, we now believe that patients who have so-called drug-induced lupus actually had vasculitis. The key point to remember in hydrolysine-induced vasculitis, you see a post-immune glomerulonephritis and double-stranded DNA antibodies. Remember that in hydrolysine-induced or drug-induced lupus, you do not get nephritis and you do not get double-stranded DNA antibodies. But in hydrolysine-induced vasculitis, you get both DNA antibodies. Next slide, please. We are moving to Wagner's granulomatosis. The best way I can offer you the clue is that it is the Mayo classification called ELKS, E-L-K-S. E stands for eyes, ears, sinuses, throats. L stands for lungs. K stands for kidney. And S stands for skin. The first thing to note is that you don't need all four. You can have E and L. You can have L and K. ANCA is highly specific, but not present in all patients. 90% of patients would have an ANCA positive. That means that 10% of patients will not have ANCA. And diagnosis is always by biopsy of an appropriate tissue. Next slide, please. Two ANCAs, you know that, P ANCA and C ANCA. The P ANCA is the myeloperoxidase positive crescentric, it causes crescentric glomerulonephritis, microscopic polyangiitis, and Church-Strauss, which we just discussed. We haven't discussed microscopic polyangiitis. There are other diseases like inflammatory bowel disease, primary sclerosing cholangitis, and primary biliary cirrhosis would have P ANCA, which is MP negative. The C ANCA is only for Wagner's. The sensitivity is 30 to 60%, specificity is 98%. That means about 10% of patients will not have ANCA positivity in Wagner's. Next slide, please. The treatment of Wagner's granulomatosis, I wrote it 5 times to remind you that that's the only treatment. It is cyclophosphamide, 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 cyclophosphamide. You may give steroids with it, but if you give steroids only, your patient will be on dialysis within a year. Next slide, please. So I have a question for you. And I have a statement and a question. Statement is, in all vasculitic conditions, corticosteroid will be the first line of therapy. Immunosuppressive agents like cyclophosphamide, Imuran are used only if steroids are not effective or side effects are unacceptable. So for example, if you have a patient with polyarteritis nodosa, you give steroids, but blood sugar jumps to 500. Or patient develops severe osteoporosis, then you add immunosuppression. Wagner's granulomatosis is an exception where you must give immunosuppressive agent on day 1. The classic is cyclophosphamide. You may choose methotrexate because it is less toxic. What is the other exception? So this is one exception I told you. What is the other exception? We talked about this, so you should be able to answer that. And that is Kawasaki. In Kawasaki, you use IVIG. You do not use steroids or immunosuppression. So treatment of vasculitis is same across the board except these 2 conditions. Next slide, please. Antiphospholipid antibody syndrome, very favorite question, particularly pops up at St. Peter's all the time because we have 6,000 deliveries here. So pregnant women come up with this and we get the consultation. The definition of this syndrome is, remember, it's a syndrome, S-Y-N-D-R-O-M-E, means things, syn means together, drome means to run. Things have to run together. So you cannot pick one and call it a syndrome. And the syndrome consists of recurrent arterial and venous thrombosis, pregnancy lost in 2nd and 3rd trimester. Pregnancy loss in 1st trimester is common, so you need more than 3 losses in 1st trimester to qualify. Thrombocytopenia, valvular vegetations, what is commonly known as Libman's sac endocarditis. And for diagnosis, presence of appropriate antibodies required, clinical plus antibody. And some, but not all patients have concomitant connective tissue disease, about 50%. That also means that 50% of patients do not have connective tissue disease. It exists itself. Next slide, please. A 21-year-old woman who recently returned from the Caribbean vacation is evaluated because of a 2-week history of malaise, ear swelling, aching of her wrist, MCP and PIP joints, and vertigo. Please don't answer until I read the question. She has no history of GI or respiratory problems. On physical examination, she has no fever. She has erythema of the malar area and pain on passive motion of the wrist. The pinnae, plural, of both ears are swollen, red, and warm. And the otologic exam is normal. Which of the following is the best test to confirm a diagnosis? That is called the stem of the question. Read the stem carefully. They want a test, and that test must confirm the diagnosis. ANA, rheumatoid factor, biopsy of the ear cartilage, X-ray of the wrist, stool culture. Please answer. Okay, I think many of you got it. Somebody still wants to. When was the last time, whoever answered ANA, I would ask them, when was the last time ANA confirmed anything? Or rheumatoid factor confirmed anything? None. The correct answer is biopsy of the ear cartilage. Next slide, please. This is relapsing polychondritis. In this case, it is not relapsing because it is the first episode. It's a systemic inflammatory disease with destruction. It affects the cartilage. So you know where the cartilages are, then you would be able to tell the clinical symptoms. Cartilage in the ear. Note that the lobule of the ear does not have a cartilage. The lobule. So in a patient who has a relapsing polychondritis, the ear is inflamed, but the lobule of the ear is spared. And that is your clue to know that this is a cartilage problem. Respiratory tract, the trachea have cartilaginous rings, so they get inflamed, and they can cause tracheal collapse. What other rheumatic disease causes a stridor? We will come to that later, but it is the rheumatoid arthritis affecting the cricoarytenoid joint. We will discuss when we come to rheumatoid arthritis. Also note the relapsing polychondritis is associated with myelodysplastic syndrome. The myelodysplastic syndrome may follow relapsing polychondritis years later. So you need to watch these people with a CBC. Next slide, please. This is the person who has a inflamed ear. You don't see the lobule, but if you had chance to look at the lobule, it will be normal. And if you look at the nose, because there is a cartilage there, is the collapse of the nose. Also note that this can occur in Wagner's disease. It can occur in congenital syphilis and some other conditions also. But relapsing polychondritis is probably the most important reason why the collapse occurs. Next slide, please. Henoch-Schönlein purpura, otherwise called IgA vasculitis. Don't confuse this with IgA glomerulonephritis. It's a small vessel leukocytoclastic vasculitis. The leukocytoclastic term is a pathological term. It's a leukocytoclastic, that means the white cells are broken up, and then there is a vascular inflammation. It's all, the clinical term would be small vessel vasculitis or Henoch-Schönlein vasculitis or Henoch-Schönlein purpura. Mostly children and young adults, 15, 16, 17 years old. It follows upper respiratory infection. It is synpharyngitic. That means the pharyngitis occurs at the same time the purpura occurs. In contrast, rheumatic fever is not synpharyngitic. You have pharyngitis first, and 2 weeks later you get the immune response. It can cause arthritis. There's a palpable purpura. I told you earlier that palpable purpura means small vessel vasculitis. It has a tendency to affect the GI system, particularly the colon, and can cause GI bleed, lower GI bleed and abdominal pain. It can cause glomerulonephritis because it is a small vessel, so glomeruli can be affected. The key point to remember by Henoch-Schönlein is that it is self-limiting and therefore only symptomatic treatment is required. Tylenol whatever you want to give for pain and discomfort, steroids are rarely necessary. The questions in the past in the boards have always been on treatment of henoxaconazole. Do not give them steroids. Do not give them immunosuppressive agents. If they want you to, they will give you the right language. Next slide, please. This is a patient. If you close your eyes and put your hands on the legs and move them up and down, they will be bumpy. It's a palpable purpura. Palpable purpura means only one thing. It's a vasculitis, small vessel vasculitis. Next slide, please. A 33-year-old man is evaluated in the ED for 5 days history of headache and right eye pain. A week ago, he developed exquisitely painful scrotal ulcers. See, they are jumping from eye to the scrotum. He does not have fever, neck stiffness, or joint pains. He has intermittent oral ulcers for the past 5 years. He is on no medications and is monogamous. Physical exam is a temperature 36.8, pulse rate is 85, respiration 14, blood pressure is normal. There are 5 ulcers in the oral mucosa. They are not telling you whether the ulcers are painful or not. The right eye is inflamed with a ciliary flush. Ciliary flush means iritis, and hypopyon is present. Hypopyon is a pus in the anterior chamber. There is no nuchal rigidity. There is a 1 centimeter ulcer on the scrotum. Once again, they are not telling you that it is standard, though I think they did tell you exquisitely painful scrotal ulcer. Is mildly anemic, white count is elevated, CT of the head is normal. I don't know why they did a CT of the head. CSF reveals leukocyte count of 13, that's abnormal, and gram stain is negative. So he has meningeal irritation. Which of the following is the most likely diagnosis? Syphilis, chancroid, Behcet's, SLE, herpes simplex infection. Please answer. The answer is Behcet's. If you can go back to the slide, I will point out what all is. Let me show you. Okay, the young fellow who has a chronic history of oral ulcers, and they are typically very painful. And now he comes in with a headache. So that's why they did an LP. He had a right eye pain. And in the eye pain, he has a ciliary flush and hypopyon. So that means he has iritis. And that is the key. Plus, he has some meningeal inflammation, and he has some systemic features. So next slide, please. There is nothing to suggest secondary syphilis here. Chancroid should not give you a painful ulcer. Syphilis should not give you a painful ulcer. SLE cannot be diagnosed because the SLE diagnosis is made on the basis of criteria. You remember the 11 criteria. Herpes simplex would not explain most of the symptoms. So if you look at the pictures, the first picture on the left is you see the white line. It is the hypopyon. This is the pus in the anterior chamber. That's hypopyon. This is the ciliary flush. Around the iris, there is a redness. That is the iritis. This is a syphilitic ulcer, which is completely painless. Behcet's ulcers are the most painful ulcers. And this could be Behcet's or could be any of the ulcerogenic disease of the penis. Next slide, please. So Behcet's is a multi-system disease, most commonly seen in Eastern Mediterranean region and Far East, but we do see it here off and on. It's a very painful oral and genital ulcer, exquisitely painful. Now, there are 3 kinds of ulcers in rheumatology: completely painless, very painful, and in between. Completely painful ulcers are Behcet's. Completely painless ulcers are Reiter syndrome. We will discuss this later. And in between would be systemic lupus, the canker sores. Their eyes are inflamed and they may have a CNS involvement, such as meningitis, and they get recurrent veno-occlusive disease. So if you insert a needle into their vein, that vein will get inflamed. And that is called pathergy. Pathergy means you give them a mild stimulus and they pop up with a pustule next day. So watch that. You will see patients who will have pathergy. Pathergy is not pathognomonic or Behcet's, but it's a heightened immune response. I don't have ability to ask questions and get answers, but I will ask myself a question. How common is pulmonary embolism in Behçet disease? Since they get a lot of DVTs, the answer is very uncommon because the clot is very adherent to the vein because of the extensive amount of inflammation, so they do not embolize. Next slide, please. Treatment of Behçet is very difficult. You give steroids, dapsone, colchicine, thalidomide. The first picture on your left is a colchicine plant, a beautiful purple plant. The middle picture is leprosy, where the hands literally fall off, fingers fall off. And the picture on the right is the unfortunate children whose mother received thalidomide during pregnancy. They were born without arms and legs, phacomelia. Just to jog your memory that that is now used as a treatment. And the classic treatment disease in which we use thalidomide is multiple myeloma. Next slide, please. This is the Behçet ulcer. You see how deep it is. That's why it is so painful. Next slide, please. This is hypopyon, which I showed you earlier. This is hypopyon in both eyes. Next slide, please. A 50-year-old woman is evaluated for a 7-day history of rash that developed in her lower limbs, but has spread to the trunk and arms. Except for intermittent fever, she feels well. So she has rash and fever, and she's 50. She was diagnosed with Graves' disease 3 months ago, and a propylthiouracil and labetalol were started, appropriate. Vital signs are normal. There's scattered, palpable purpuric lesions on her lower limbs. So you already know that she has small vessel vasculitis. You do not get palpable purpura without small vessel vasculitis, and on trunk and arms. The remainder of the exam is normal. ESR is 50, which is elevated. P ANCA is positive. Remember, in Wagner's, you get C ANCA. And hepatitis B virus surface antigen is negative. Urine is clear. Skin biopsy reveals leukocytoclastic vasculitis, which is a small vessel vasculitis. Which of the following is the most appropriate next step in patient's management? Discontinue labetalol, discontinue labetalol and begin prednisone, discontinue PTU, discontinue PTU and begin prednisone. Please answer. Okay. Do we have the answer or shall I go ahead? Okay. Discontinue for PTU and prednisone. Okay. Number one, that is a wrong answer. You do not want to give prednisone because there is no compelling reason in her history to save an organ. She has a skin disease. She has a rash. You don't want to give, and this is propylthiouracil induced vasculitis. If you move to the next slide, I will explain. Next slide, please. Okay, PTU-induced vasculitis may occur weeks or months after starting therapy with PTU. I've seen one where the PTU was given 6 years ago and the patient came with a vasculitis. P ANCA is positive in this patient. And manifestations include cutaneous vasculitis, the leukocytoclastic or small vessel vasculitis. They can get glomerulonephritis and they can get pulmonary hemorrhage. Now, if they have glomerulonephritis and pulmonary hemorrhage, you may want to give prednisone, but not for skin. Note that P ANCA is also found in microscopic polyangiitis and Church-Strauch syndrome, and also in inflammatory bowel disease, primary biliary cirrhosis, sclerosing cholangitis. So far, I've told you 2 drugs which cause vasculitis. One is hydralazine, the second one is propylthiouracil. Next slide, please. A 27-year-old woman is evaluated because she has a spontaneous abortion 6 weeks after becoming pregnant for the first time. Anything related to pregnancy determine which trimester it is. This is T1. Lab studies reveal presence of anticardiolipin antibodies. Levels of IgG and IgA are normal. IgM level is low positive. Sensitive partial thromboplastin time and modified Russell Viper venom test is normal. Which of the following would be the appropriate management during the patient's next pregnancy? She already lost one baby after 6 weeks. Warfarin, heparin, prophylactic, heparin therapeutic, aspirin 81, no treatment. Please answer. Okay, I think this was a difficult question for many of you. Before you give any treatment, what's the diagnosis here? We went over this antiphospholipid antibody syndrome a few minutes ago. You need a bunch of clinical scenarios, one of which is pregnancy loss, but it is in second and third trimester. This woman lost the baby in 6 weeks, first trimester. That is not considered a clinical criterion. You have to have at least 3 losses in first trimester. And this antibodies, low positive, has absolutely no meaning at all. That is just a distractor for you because they want you to answer something like aspirin or heparin or even warfarin. The correct answer is no treatment. This woman does not have antiphospholipid antibody syndrome. Remember, it's a syndrome. She has nothing. They're not giving any information whether she had any. Remember, the number one criterion for syndrome is arterial and venous thrombosis on a recurrent basis. She doesn't have. Pregnancy loss in T2 and T3, she doesn't have. And thrombocytopenia, they're not giving you. That means you have to assume she doesn't have. One of the most common problems we see at St. Peter's, because we deliver a lot of babies, is this pseudo antiphospholipid antibody syndrome. Women are labeled because of the antibody, but you have to meet with the clinical and the serological criteria. Very important question. Next slide, please. A 16-year-old male is evaluated in the emergency department for a 2-week history, persistent fever, abdominal pain, and right knee pain, monoarticular pain. During the past year, he has had 3 similar episodes. He takes no medications. So in 1 year, this is his 4th episode. He has a fever. His blood pressure is okay, sort of. Heart rate is 96. There's a diffuse abdominal tenderness without rebound and no evidence of hepatosplenomegaly or lymphadenopathy. The right knee has an effusion with limited range of motion, so that right knee is inflamed. A well-demarcated, raised, erythematous, warm, and painful rash is noted on the right lower limb over the shin. Next slide. ESR is 42, which is elevated. Serum ferritin level is normal. ANA is negative. Urine shows 1+ protein, no cells or cast. Which of the following is the most likely diagnosis? Adult onset Still's disease, Crohn's disease, familial Mediterranean fever, and reactive arthritis. Please answer. Okay. I think half of you got the correct answer. The correct answer is familial Mediterranean fever. Adult onset Still's disease should give you very high temperature, huge spike like 105, 98 next day. The ferritin level should be significantly high. This person has a normal ferritin level. This is not Crohn's disease. Crohn's disease should not give you abdominal pain, should not give you monoarthritis, should not give you recurrent over 1 year. Reactive arthritis implies that it's a reaction to something. There is no such thing here. Reactive arthritis is typically not monoarticular. This is a classic familial Mediterranean fever. Next slide, please. The very important thing, and we always think that familial Mediterranean fever is seen in Turkey and places neighborhood. No, it is seen in the United States in any population, but the important point to remember is that 10% of them start in adulthood. That's why it becomes part of internal medicine. It's an autosomal recessive, so you may get a family history. They have recurrent fever with serositis. That's why they have abdominal pain. They have literally peritonitis. In older days, before the era of CAT scans, These people had exploratory laparotomies all the time, and they would have multiple scars on their belly. We no longer see that because we have CAT scan. They develop synovitis, typically of large joints and large joints and monoarticular or maybe oligoarticular. And they have, remember they described a rash on the legs, on the shins, raised, red, tender, that is recipiloid rash. There may be proteinuria because one of the complications of familial Mediterranean fever is amyloidosis. And the magic of this disease is that if you give them 0.6 milligrams of colchicine every day, you will prevent all the complications. They will not have fever, they will not have arthritis, they will not have abdominal pain, they will not have amyloidosis, and they will not have renal failure. These kids used to die by the time they reach 18. Just imagine the value of colchicine. 0.6 milligram costs 1 cent in Turkey. United States, 0.6 milligram costs $16. But still cheap. And don't miss this diagnosis. Next slide, please. There are vasculitis mimics. I think you know them all. Cardiac myxoma can emboli and can mimic vasculitis. Infective endocarditis is classic. TTP, HUS, another thing which can mimic. Atheroembolism we talked about. We don't see ergotism in the United States, but immigrants bring ergot preparations with them and they may get that. And we already discussed antiphospholipid antibody syndrome. They can mimic vasculitis. And remember that in antiphospholipid syndrome, there is no inflammation. It's only clot. Therefore, steroids don't work, NSAIDs don't work. You have to give anticoagulation. The pathophysiology is so important. And once you know that, you will know the treatment. In antiphospholipid antibody syndrome, you do not give anti-inflammatory medicine unless they are accompanied by a connective tissue disease like lupus and you want to give steroids for that reason. Many infections cause vasculitis mimic Lyme disease, rickettsial fevers, HIV, and few others. Next slide, please. Okay, we finished vasculitis. There were 58 slides on that. So hopefully you learned something. Now we are going to go for acute low back pain. Acute low back pain is an orphan disease. Nobody owns it. It's owned by physicians, primary care, orthopedics, neurologists, neurosurgeons, chiropractors, mostly chiropractors, and few others. And nobody owns it. But there is some science finally in acute low back pain. So if you remember, we are only going to discuss acute low back pain, not chronic. It's a different disease. If you take thousands of patients of acute low back pain walking in your office, this is the epidemiology. 4% will have compression fractures. 0.7% will have cancer, either primary, like multiple myeloma, or a metastatic, most likely metastatic. 0.3% will have ankylosing spondylitis. Ankylosing spondylitis does not cause acute low back pain. It causes subacute and chronic, but they put it in the algorithm so that you never miss it. And 0.01% will have spinal infection like vertebral osteomyelitis or disc space infection or epidural abscess. So when you see 1,000 patients, you will have to figure this out. If you can exclude this 4 and any obvious neurological compromise, that will make 95% has no consequence. You can do anything you want with them, ignore them, give them placebo, give them ibuprofen, but you don't have to worry about them because they will self-resolve. In 14 days, 80% of people with acute low back pain will resolve by themselves. So if you want to do one thing, don't do anything for 14 days. So let's go to the next slide. So what they have developed red flags and yellow flags. Red flags are to identify those 4 things I just told you. Yellow flags are to identify which patient will become chronic. Acute back pain, about 1 in 4 will become chronic. And you need to identify that patient upfront. We don't have time to discuss that here. So I will only discuss the red flags for those 4 things. Next slide, please. So what are the red flags for fracture? Osteoporotic fracture, age over 70, history of trivial trauma, picking up groceries from the uh, trunk, that kind of trauma, and history of corticosteroid intake at any time in the past. This is your number one clue. So when a patient walks in your office, she's 70 years old, she's likely to have osteoporosis and likely to have a fracture. The first question you will ask, ma'am, have you ever taken prednisone, cortisone ever in your life? And she says, yes, at 40, had asthma, I took cortisone for 6 months and then I never took it. That woman has 98% probability of having an osteoporotic fracture. 98%. There are not too many things in medicine where you have 98% probability. So a simple question, did you ever take cortisone? And the dose is 1 gram of prednisone in a lifetime. Remember that 1 gram. So it doesn't have to be a lot. And you all know that we give enormous amount of prednisone to our patients in ICU all the time. Somebody comes with asthma, they get Solumedrol 125 milligrams on day one. That person is lifelong compromise for fracture. Next slide, please. What are the red flags for neoplasm? Here, the age is 50. Previous history of cancer at any time. That has a 97% probability of having a metastatic disease. So somebody walks in your office, the woman is 70 years of age. She's perfectly okay, except that at the age of 40, she had a lumpectomy and radiation therapy. And she's fine, cancer-free. Now she has acute low back pain. She now has 97% probability of having a metastasis. So you will ask that question, ma'am, did you ever have any cancer? And if they have a cancer, either breast, prostate, colon, and they have a back pain, you have a diagnosis. Pain lasting for more than 1 month, that's a red flag. I told you 86% of patients will get relief in 14 days by themselves. Failure to improve with conservative treatment and pain relieved by bed rest. When you lie down, your spinal pressure on your vertebral column drops significantly. So if you have a back pain and you lie down, your pain goes away. If they persist in having pain at night when they're lying down, that's a red flag and you need to investigate. Next slide, please. What are the red flags of spondyloarthritis? Morning stiffness. They wake up stiff in the morning, their back is bent over, they take a shower, they have coffee, breakfast, they improve. That is an inflammatory back. And it improves after exercise. Typical onset is a teenager. You know, a teenager is dragged in your office by the mother. He's 17 years old and he has a low back pain. You are going to think sports injury. No, think about spondyloarthritis because it would be missed. It's insidious, it's not acute. And if the pain is more than 3 months, think about spondyloarthritis and do appropriate test studies. The next slide, please. Red flag for infection. Focus of infection present at the time of your seizure, and that includes indwelling catheters, skin infections like pustules, bad acne, urinary tract infections, and IV drug abuse. So a 25-year-old man or a woman walks in your office, has a history of drug abuse and has a low back pain. That person has spondylo infection, vertebral osteomyelitis, unless proven otherwise. So watch out for infections and do the appropriate testing. Next slide, please. Now this question, I want you to look for red flags. A 39-year-old man is evaluated for severe low back pain for 1 week duration. The pain began on Saturday night after he removed heavy carpet from his apartment floor. He took rest, heating pads, ice packs, deep heating lotions, and ibuprofen, but that did not give him much relief. On physical exam, he is moderately overweight with substantial muscle spasm and tenderness over the right lumbar region. There is no pain during straight leg raising test, which is a stretch of sciatic nerve, and a deep tendon reflexes are brisk but symmetrical. So there is no neurological deficit. He has no fever or other symptoms. He recalled throwing his back out, whatever that means, several years ago during a move into his current apartment. So clearly this is related to some physical work. His symptoms resolved after a few days. Last week. Next slide, please. His family history includes the father who underwent a discectomy at the age of 60. He smokes less than a pack of cigarettes a day and drinks alcohol socially on weekends. Which of the following is the most appropriate next step in the management of this patient? Anytime they ask you management, it can be a diagnostic step or it could be a therapeutic step. Management includes both. A, non-steroidal anti-inflammatory and increasing activity is tolerated. B, X-ray of the lumbosacral spine. C, there's a typo, HLA-B27. D, tricyclic antidepressant. And E, orthopedic referral. Please answer this. Okay, my question to you is that did anybody find any red flags? No. He has all kinds of story about it, lifting the carpet, etc. So most of you got the answer correct, 60%. But those of you who did X-rays do not have idea about the choosing wisely. You should look it up. HLA-B27, some of you wanted to do it. So let me just walk you through the answer. The correct answer is A, HLA-B27. Let's get rid of that quickly. Next slide, please. First of all, it is not a test. Do not order it, ever. Okay? Because 8% of Caucasian people have HLA-B27, healthy, jogging in the park people. 4% of African Americans have HLA-B27. So anything which is 8 and 4% in the community cannot be a test. However, 90% of patients with spondyloarthritis have HLA-B27 positive. So it has a value, but not as a test for back pain. That is absolutely out. Next slide, please. So going back to the question, I think there was one slide missing on that's my fault. A patient I presented has no red flags. So you give them symptomatic treatment for a couple of days. Don't keep them in bed. Do not put them on disability. Give them analgesia, mild analgesia. Do not give them narcotics, because once you give them narcotics, he'll be your patient forever. Do not give them narcotics. Do not give them physical therapy. There is no need for that, because that's another abuse. You just let them take something like ibuprofen, 24 hours stay at home kind of thing. I don't have time to explain what kind of rest, and that's about it. If they have red flags, then you go for the diagnostic imaging. If you think it is a fracture, you take a plain X-ray. If you think it is a osteomyelitis, you do the MRI, things like that. Let's talk about lumbar spinal stenosis. Always a favorite question, always pops up in the office. Lots of people have lumbar spinal stenosis, almost like an epidemic form. So we need to know clearly what it is. Number one, it causes intermittent claudication. The person walks a block, stops, as the picture shows on your left, and then rubs his legs and walks again. How do you distinguish from vascular claudication? If you have a peripheral vascular disease, you have the same thing. You cannot distinguish vascular claudication from neurogenic claudication by claudication history alone. You have to have something else. People with lumbar spinal stenosis will have pain on standing up. So they do not have ability to stand up and do dishes, for example. They have pain. They will get a stool to sit down. Men will not shave standing up. They will sit down on a stool to shave. They will not go to a bank when it's a busy bank day because they have to stand in a queue. These folks cannot stand. So that is your clue of spinal stenosis. They get pain walking downwards. So if they're going down the stairs, they get pain, but going upwards is not a problem. And that's counterintuitive. Why is that? Because spinal canal becomes narrow when you're standing up. Because when you're going down the stairs, you have to stay erect. Because if you bend forwards, you will fall. Therefore, when they do a shopping cart, as the picture on the right shows, they can do the entire shopping for a couple of hours. But they go to the mall, they will not be able to do shopping because there is no shopping cart in the mall. So the treatment for these people is that let them buy a little portable shopping cart and they can go to the mall. They can have neurogenic symptoms, and the test to perform is MRI. Do not send them for surgery. Give them physical therapy because surgical results are not good at all. Next slide, please. Spondyloarthritis. We are coming to the last topic here. I think I'm running a good time. Spondyloarthritis, the prototype is ankylosing spondylitis. Then we have Reiter syndrome, otherwise now called reactive arthritis. Reiter was a war criminal, so there is a movement in the country to remove his name. He tortured patients, so it is all now reactive arthritis. Then there is an enteropathic arthritis. That means the disease is in the gut, like Crohn's disease or ulcerative colitis or even C. diff, and you get a reactive arthritis. And the last one is psoriatic arthritis, which is reactive, which we will discuss in details. Next slide, please. So let's talk about spondyloarthritis. It's a systemic inflammatory disorder. It is not just a disease of the spine. However, it affects mainly the axial skeleton. On the picture on your right, the axial skeleton is the spine. Everything else is the appendicular skeleton. Enthesitis is common, and enthesis is a place where the tendon attaches to a bone. So your tendo-Achilles inserts into a calcaneum, that is an enthesis. And for some reason we don't know about, spondyloarthritis inflames the enthesis. If you have a pain on the elbow, the lateral epicondyle, where the flexor muscles are inserted, that is an enthesis. So they get tennis elbow very often. And I told you earlier, there is a very tight link with HLA-B27. But I again remind you that HLA-B27 is not a test. Next slide, please. I like this picture very much. This is done by one of the rheumatologists who photographed, because there was nothing he could do. There was no treatment for this condition. When I was a fellow in rheumatology, I saw the patient in the right, the 1973 picture. You will see the picture on the left, 1947 picture, because that's why they added low back pain in the algorithm I gave you, the four things you must rule out. If you go to middle of the picture or the end of the picture, you're too late. You already have caused ankylosis in many joints. So look at the fellow on the right, 1973. His knees are bent, his hips are bent, his elbows are bent to some extent, his spine is bent, his neck is bent. So try to bend your neck and walk. You will not see anything, you will only see the floor. So these people fall all the time. In the middle picture in 1967 and 1972, using a cane. In the 47 picture, he is straight, but lumbar lordosis is still there. So next slide. We all know about the features of skeletal features of spondyloarthritis. It is sacroiliitis and all the way up to atlantoaxial joint. But I want to remind you the extra skeletal features of spondyloarthritis. Because it is an inflammatory disorder, any inflammatory disorder will cause osteoporosis of the bones and fractures. So what is the learning point? You need to do DEXA scans at a certain period, and you need to protect them from osteoporosis. These patients also get anterior uveitis. They get cardiovascular involvement, and I'll tell you how. They get pulmonary fibrosis. There is a generic rule that all rheumatic disease, lupus, rheumatoid, polymyositis, scleroderma, they all cause pulmonary fibrosis, but they affect the basis. This is the exception. Spondyloarthritis affects the apices of the lungs. They also cause restrictive thoracic movement because remember the 12 ribs, 24 ribs are attached to the sternum and the vertebral column. They're all joints. And this disease affects those joints, so your thorax doesn't move much. So one of the things you do during office hours, you measure the chest expansion. Take a tape put it around the chest, and measure the expansion. You'll be amazed how restrictive the thorax is. So imagine this, a patient with spondyloarthropathy has a restricted thoracic movement, has an apical fibrosis, and on top of that, he smokes. So now he has restricted thoracic disease, he has restrictive lung disease, and he has obstructive lung disease. So one of the most important things we do is to have them stop smoking. We do that on everybody. The other complications, which is not commonly known, is cauda equina syndrome. So they might give you a patient with spondyloarthritis who comes with weakness of the legs and bladder bowel dysfunction. So why do they get cauda equina syndrome? They have inflammation of the arachnoid membrane. It is arachnoiditis at the cauda equina level. So all the nerve roots are trapped in a jello, literally jello. There's nothing you can do. The other new thing is, if you colonoscope, they have no GI symptoms. Ankylosing spondylitis has no GI symptoms. But if you scope them, colonoscope, you will find mucosal ulcers in the cecum. So many people believe that spondyloarthritis, ankylosing spondylitis, is probably an enteropathic arthritis. And any inflammatory disease, you may get a secondary amyloidosis. Please note that the commonest cause of amyloidosis in the United States is rheumatoid arthritis. The commonest cause of amyloidosis in the world is tuberculosis and bronchiectasis. Next slide, please. This is the apical fibrosis. When I was a fellow, we were told that people with ankylosing spondylitis get tuberculosis. This was thought to be TB. It looks like TB, isn't it? But it is apical fibrosis. Of course, you have to do the workup to make sure it is not tuberculosis. Next slide, please. The picture on the top is a section of a healthy aorta. And you see how well organized it is. The picture on the bottom is a aorta taken from a person who died from ankylosing spondylitis. See how disorganized it is? So no wonder they get aortitis. I told you earlier, aortitis occurs in GCA, Takayasu disease, syphilis, and spondyloarthritis. This is your sample. Next slide, please. Spondylitis and cardiovascular complications. You get ascending aortitis. You can get, as a result, dilatation of the aorta and aortic insufficiency. And for some reason, it affects the conducting system. So you get heart blocks, and they may need a pacemaker. There are two rheumatic diseases which affect the conducting system. One is this, and other one is a baby in a mother with lupus. They get congenital heart block. Why that occurs, I don't know. Next slide, please. How do people die? People do die from arthritis. How do people die from ankylosing spondylitis? They have typically cervical fractures, because cervical spine becomes a one rigid bone. I'll show you a picture in a few minutes. Or they may die from heart failure as a result of aortic insufficiency, or they may die from amyloidosis and its consequences. Next slide, please. Management is fairly straightforward. Here, NSAIDs become the most important treatment, and specifically indomethacin. Why indomethacin works, we don't know, but it does have a more powerful effect than physical therapy. Now, you have to be very careful. What kind of physical therapy are you giving to these people? Remember, they bend. When we are born, our flexors are stronger than our extensors. That's why the baby can be in a fetal position in the mother's womb. But that remains throughout your life. So when you get older, or you get spondyloarthritis, or you get weak, you will bend. You never get straight in old age. You bend. So, can you go back, please? When you give physical therapy, tell the therapist to train their extensor muscles, because that's what you want. Do not give them a bicycle, because bicycle will train their flexor muscles because they bend over. You can use traditional DMARDs for axial, the traditional DMARDs like methotrexate, chloroquine, they do not work for spine. They may work for appendicular disease because there is an appendicular expression. For the spine, you use tumor necrosis factor inhibitors, biologics. Next slide, please. Do not use corticosteroids in this condition ever, because they have osteoporosis. Now in rheumatoid, it's a different matter. Rheumatoid, it's a different matter. You use steroids in certain situations. But here, you do not use corticosteroids as long as possible. It doesn't work, first of all. Watch for bone mineral density, make them stop smoking, and very rarely use thalidomide if biological do not work, but only for refractory disease. Next slide, please. This is the bamboo spine. People don't believe me when I show them, so I put a bamboo picture there. You can see that, why it is a bamboo spine. And the pathology of this is the anterior longitudinal ligament is calcified. This is this line. And these are called, and they are symmetrical on both sides. They are very fine, very thin syndesmophytes. Now, in contrast, you will see the syndesmophytes of osteoarthritis. Next slide, please. Look at the syndesmophyte here. This is osteoarthritis. They are large, they are asymmetric, there is nothing here. They are mostly on this side, and they are horizontal. They don't go up or down. And if you go one more time in the back, Teresa, I will show you again the bamboo spine. Look at the syndesmophyte, how thin they are and how symmetrical they are. And they go upwards. In the next slide, you see the syndesmophyte of osteoarthritis. They're both called syndesmophytes, but they are totally different. Next slide, please. A 52-year-old man is evaluated for 2 weeks of increasing neck pain. He has 20 years history of ankylosing spondylitis. On physical exam, he has limited range of motion of the thoracolumbar spine, similar to the results of previous exams, but significantly increased range of motion of the neck. He notices this improved range after his involvement in a motor vehicle accident 3 weeks ago. The rest of the examination is normal. Okay? Which of the following is the most appropriate next step in management? ESR, plain radiograph of the cervical spine, tapering doses of prednisone, physical therapy, indomethacin. Please answer this. Okay, I think I'm glad everybody got it more or less, but some people want to give physical therapy. You will kill him if you give him physical therapy. This is a fracture of the cervical spine. I told you that there are 7 cervical vertebrae. Why did nature created 7 vertebrae? There's a reason for that, because they are protected. You take a long pencil, the whole pencil, you can crack it and you make it into half. But if you take a stub of a pencil, you cannot break it. Now, this gentleman had a mild accident 3 weeks ago, and the clue is that his cervical spine range of motion, which was restricted before, now has increased. So something is loose, and therefore he has broken the spine. He's lucky that he didn't get quadriplegic. So the correct answer for this is plain X-ray of the cervical spine to detect the fracture. It doesn't need prednisone. You never give prednisone in spondyloarthritis. Physical therapy, or even worse, chiropractic would kill him. Indomethacin will not do anything. Citrate never makes a diagnosis. So let's go to the next slide. This is what happens in chiropractic. You see the person cracks the neck. The next thing you know is quadriplegic. This is what happens in the car. You're driving at 10 miles an hour, not very high speed. Somebody hits you from behind. You are stopped at the traffic light. You have a flexion, extension, flexion, the whiplash injury, the spine cracks. So the learning point here is you should be aware of this. Your spondyloarthritic patient must wear a collar while he's driving or while he's a passenger. They refuse to do so. I try to convince them. And then there is a little gadget in the back of your seat which goes up and down to adjust your neck. Make sure that that is adjusted to patient's proper height. Next slide, please. Psoriatic arthritis, we are coming to an end. Traditionally, psoriatic arthritis is divided into 5 subtypes. I want you to know that there is an overlap. So you don't get one or the other. You may get number of them at the same time. The most classic form of psoriatic arthritis is involvement of the distal interphalangeal joints. The only disease which affects distal interphalangeal joint is osteoarthritis, the Weber-Dense nerves. Gout can do that, but typically it's a DIP is osteoarthritis. Or you can get asymmetric large joints oligoarthritis. Each word is important. So it's asymmetric. So left ankle, right knee. Large joints, knee, elbow, ankles, not small joints of the hand. And oligo, by definition, oligo means 2, 3, or 4 joints. So if you get that picture, it is most likely psoriatic arthritis or reactive arthritis. There is a tremendous similarity between the reactive arthritis and psoriatic arthritis. Then you can get a rheumatoid arthritis-like picture, small joints, symmetrical, but rheumatoid factor and anti-CCP antibody is negative. That is another form. Or you can get spondyloarthritis, sacroiliac joints going upwards. And lastly, arthritis mutilant, mutilating arthritis, fortunately very uncommon, but these are the 5 types. You can have an overlap of each one. Next slide, please. This is a patient where if you look at the third finger, there is a swelling and redness of the distal interphalangeal joint. This is a classic acute inflammatory psoriatic arthritis. Could this be osteoarthritis? What is called a erosive osteoarthritis? Yes. But you will determine that by the company it keeps. If this person has psoriasis of the nails or somewhere else, then it is psoriatic arthritis. Next slide, please. The treatment of psoriatic arthritis, NSAIDs, should not give aspirin because aspirin seems to exacerbate psoriasis. Antimalarials are not indicated in psoriatic arthritis because they exacerbate psoriasis. And if the person is on steroids for some reason, and if you withdraw, then psoriasis may exacerbate. Keep this in mind. The other point to remember, there is no relationship between the extent of the skin disease and the extent of the joint disease. For example, there's a condition called gutte psoriasis, G-U-T-T-E. That means a drop of psoriasis and a lot of arthritis. So when you see a person, let's say somebody walks in your office with inflammatory arthritis of the left ankle, right knee, and left elbow, and there is no psoriasis. So it is either psoriatic arthritis or reactive arthritis. There is nothing suggestive of reactive arthritis. So you need to search for psoriasis. The places where psoriasis hide is in the scalp. So you have to examine the scalp carefully. Behind the ears, the umbilical region, the navel, you have to look inside, and the gluteal cleft. That may be a drop of psoriasis. If you miss that, you'll miss the diagnosis. So search, there is no test. There is absolutely no test. Next slide, please. Reiter syndrome, otherwise called reactive arthritis, the better name now is reactive arthritis. The classic description was arthritis, conjunctivitis, and urethritis. It's a seronegative. When you use the word seronegative, it means rheumatoid factor negative. It's asymmetric, I told you, oligo, 2, 3, or 4 joints, and large joints. It has a mucocutaneous manifestation, balanitis, inflammation of the glans penis. Painless ulcers, we talked about painful ulcers or Behçet's. Now these ulcers are painless. I'll show you a picture. And the classic skin manifestation of reactive arthritis is what is known as keratoderma blunorhagicum. Big name, but very simple. I'll show you a picture. You can get onycholysis, breakdown of the nails, and you get sausage digits. Sausage digits occur because there is an enthesitis on the digit, so the entire digit swells up like a sausage. Next slide, please. This is conjunctivitis, fairly diagnostic looking at it. Next slide. This is balanitis. If you look at the picture on the right, the meatus is slightly red. You can almost ignore it. Patient may have a mild symptom of urethritis. Picture in the middle is a all keratinized glans penis, and picture on the left is much more. The interesting thing is the fellow on the left and the middle will have no symptoms at all. So he comes to you with arthritis of the elbow and knee, and you ask him to take his pants off, and he's going to look at you funny. So why do I have to take your pants off? Because if you miss this finding, you're not going to make a diagnosis of uh, reactive arthritis. This is critical, absolutely critical. There is no test. You have to find this. Next slide, please. This is the superficial ulcer. Remember the Behçet's ulcer that I showed you? This is a classic ulceration superficial. Patient doesn't know this. You have to find them. They may be on the tongue. They don't burn. They don't hurt. They can eat spice. But they are superficial ulcers, and they could also be on the palate. Next slide, please. This is a classic form of keratoderma blepharospasticum. I don't have to describe it. Once again, the patient is not aware of that. Most people don't look at their feet. We ask diabetics to buy a mirror and look at their feet. This is the guy who doesn't know this is happening. And if you see this, there's no other diagnosis other than keratoderma blepharospasticum. Next slide, please. When I say that the digits become sausage-like, nobody believes me, so I put a sausage there for you. The entire digit is swollen. And that is because there is arthritis of the joint and there is enthesitis in the middle. So the entire digit gets swollen, and it's fairly classic. You see it, you will diagnose within a minute. Next slide, please. I think we are coming to an end today. This is, I think all of you know, erythema migrans, central lesion clearing outside, and again a red circle, and that is erythema migrans. You see this, what is the next test you will do? None. Do not do serology. That's absolutely unnecessary. This is diagnostic. It's like herpes zoster. You see herpes zoster, you don't do a test, you treat. Next slide, please. So Lyme disease is a multi-system disease, as you all know. Most patients cannot recount the history of tick bite. Majority of the people will not recount, and those who do not have Lyme disease usually. So I think we ask them, but I think exposure to woods is probably important, and they get this erythema chronicum migrans. In the primary, in the secondary stage, they get meningoencephalitis, and this is another disease which may cause mononeuritis multiplex. I defined mononeuritis multiplex for you earlier in vasculitis. This is an infectious disease which may cause mononeuritis multiplex, and the most common manifestation is facial nerve palsy. It can be bilateral. They can also get myocarditis, and this is another disease which affects the conducting system. So I told you two diseases which affect the conducting system. One is spondyloarthritis, other is baby in a mother who has lupus, and this is the third one if you want to Lyme disease. I think this is the last slide for today. Next slide, please. I just want to remind you that everybody knows Lyme on the Northeast, but in the boards, for some reason, they are always giving you Wisconsin. The Wisconsin is as endemic as Connecticut. So Wisconsin is up north. So watch the state, which state they are giving you. Next slide, please. So this is the summary slide for Lyme disease. Think Lyme disease when they ask you Martha's Vineyard, Connecticut, or Wisconsin for your boards. Remember, co-infection can occur. You can have Lyme disease and babesiosis or something like that. Erythema migrans is pathognomonic. Do not do serology. Treatment is doxycycline, amoxicillin, or ceftriaxone. You do not give hikers prophylaxis. There are some compelling reasons to do so, but not otherwise. People will come to you and will ask you, Doctor, I'm hiking tomorrow. Can you give me some tetracycline? Do not treat chronic Lyme disease with antibiotics. There is no such thing. Do not rely on serology to decide on adequacy of treatment. A lot of people do that. They do antibodies and then they give antibiotics and then they check the antibody titers. Please don't do that. And do not prescribe doxycycline in pregnancy or in children. I think we are at the end, right, Teresa?
We are at the end. We have a few
Okay.
minutes. If anyone has any questions on what was presented tonight, if they could put them in the chat, we'll try to answer them for you.
Okay, there are a whole bunch of chat things here.
Most of them are answers to some of the
Okay.
questions that were asked. So let's just give it a minute or two to see if anyone has any questions that they want to put into the chat. And everyone seems very happy. You did an awesome job, Dr. Kothari.
Well, I don't know about that. I think the audience has to tell me. I don't get any feedback.
It's hard to present in a webinar. There you go. You're getting, if you have the chat open, excellent session. Dr. Kothari has always had his best when he teaches rheumatology. Looking forward to more sessions. Awesome. Thanks.
Yeah, I object to that. I object to
Thanks.
that. I teach other than rheumatology.
Thank
Okay.
you so much.
Okay, we have either.
So I think we're getting just very good feedback. Please, everyone, oh wait, here's what does the sausage digit of psoriatic arthritis, what does the sausage digit of psoriatic arthritis?
Yes, they are similar because
Similar.
they both have arthritis of the small joints as well as enthesitis. Yes, they can be very same.
So that looks like all our questions and comments. Please, everyone, mark your calendars for next week, February 17th at 5 o'clock, and we will join into session 2.
Okay, thanks everybody for your attention. I appreciate that. And thank you, Teresa,
You are
for
welcome.
doing a very difficult word. I think you prevented nervous breakdown in me today.
I'm
Thank you.
happy to help.
No, thanks very much.
Thank you, everyone. Good night.